All right. So yeah, thank you everybody for joining us today. We have a good group. Please do introduce yourselves in the chat as you're coming in. So I'm Kelsey. I'm the program manager with our MapNet group here in Massachusetts, focusing on first episode psychosis and its treatment. So we're really happy to have Dr. Kelly Irwin here today to talk about something that I think does come up pretty often, is this question about health equity for people with serious mental illness and how to be thinking about and helping folks with some of these issues that we know are going on. So as a brief introduction, Dr. Kelly Irwin is an assistant professor in psychiatry at Harvard Medical School and a faculty psychiatrist at the Mass General Hospital Cancer Center and Schizophrenia program. So she's the founding director of the Collaborative Care and Community Engagement Program, which is a clinical and research initiative dedicated to improving cancer outcomes for individuals with serious mental illness within the Center for Psychiatric Oncology and Behavioral Sciences at the Mass General Cancer Center. So I think Kelly really comes from has a good perspective to be talking about these issues, in general, and also specifically about how they relate to cancer care and, within our system here in Massachusetts, which I know we have a pretty unique and special health system. So really glad to have you, Kelly. Thank you for coming on, and I'll hand it over to you.
Thanks so much, Kelsey. And it's nice to be here with everybody. I recognize a few familiar names from my prior work at North Suffolk and some recovery-based work. And I would just offer, this hopefully will be a dialogue. And so I would really encourage questions and comments. I think, language is important to talk about, and everybody doesn't prefer the same language. And so I invite a dialogue about that too. I'm happy to talk more about that as we go through. When I am grounding myself to think about why I do this work and what brings all of us into the room, I think often this is a quote that I like to start with. This is Susan Sontag. And as she writes these words, she's writing about cancer, but I think we can also think about mental health needs as we listen. Everyone who is born holds dual citizenship in the kingdom of the well and in the kingdom of the sick. Although we all prefer to use the good passport, sooner or later, each of us is obliged to identify ourselves as citizens of that other place. So from my perspective, I come to this work not only as a researcher and psychiatrist, but also someone who is personally affected by my mental illness. And that really grounds my perspective in what I think it means to be strength-based, why I think that this is a human rights violation, and what it means to sit with someone and hopefully accompany them to get the care that they need. So as you guys know, words matter. This is a word cloud that was generated from qualitative interviews with mental health clinicians and oncology clinicians about the experience of caring for individuals with schizophrenia. And I think there are a lot of different words here that hold a lot of different judgment sometimes, and I think often come up not only in casual conversation, but also documented in the medical record. And I think have meaning and impact the experience of care and what needs to change to start to eradicate these health disparities that are affecting so many people who are living with psychosis. So if you Google Cancer Center and you Google mental health clinic, if you like, we could substitute any acute cardiovascular specialty center, but this is my context. This is what you see. So you see a bright, shiny glass building, or you see a strip mall. You see a place that really gives off the impression of how much we're investing in it versus something that's more forgotten. You see a place that likely doesn't share a medical record, that may not have clinicians walking amongst the two buildings, that may in other ways be fragmented, segregated, or differently resourced. What implications does this segregation have? This is the big one, right? The fact that there is a significant preventable mortality gap. And these statistics are drawn from Massachusetts-based data. We know that even though these numbers are old, that this mortality gap persists. And whether it's 25 or 30 years, the big picture here is that it is a significant and preventable mortality gap, and that 80% of that mortality gap is due to medical illness. Much like the general population, the number one cause of death amongst people with serious mental illness is cardiovascular disease, and the number two cause of death is cancer. And so the question becomes, if we're going to try to take steps together to close this mortality gap, how might we do that together? And how might we understand those causes and take action together? And that's really been the driver behind our clinical research program and our advocacy work in partnership with the Department of Mental Health and other collaborators. So if we were to think specifically more about cancer, just as an example, one driving message is that specialty medical care has had incredible advances, particularly cancer care, and this continues to this date. Things are radically changing, and we know that survival is improving. We can look at it, 75% of people with breast cancer, surviving at 5 years in 1975 to 90%, and that number keeps going up. But the important issue here is we know that not all people are benefiting equally from those changes and from those advances in specialty care. And we know that individuals with serious mental illness experience a double disparity that's not solely explained by poverty-related barriers or other driving barriers in the social determinants of health, but even on top of that, there's a specific disparity that's experienced by individuals with schizophrenia that's quite marked. If you look at the example of breast cancer, think about a 2 to 4 times greater mortality from breast cancer. We can unpack that more. We can say, okay, is it just that people with breast cancer and schizophrenia are more likely to die, or do we know that they're dying from their cancer? So we know that that's also higher. And then from there, I am an interventionist, someone who likes to look for modifiable factors to target so we can mitigate this mortality gap. We can start to unpack what might be some of those potential drivers that we could target. So if we think about that together, we think about the continuum of cancer care or the continuum of any real trajectory of medical care. What we can see is that across that continuum, there are modifiable disparities. I'm going to take you through just a little bit about that with the example of cancer care, and then really want to spend more time talking about the wheel that's above there, and what it means to think about kind of those levels at the level of the person, the level of clinicians, our health system, and just the pervasive mental health discrimination and how it affects all those multiple levels. We could talk about culture and policy as well. But at a first level, kind of thinking, as I was saying, as an interventionist, let's break down kind of the trajectory or pathway of cancer care. What we've learned is that there are disparities in certainly cancer screening. We talk a lot about also cancer prevention, rates of tobacco use, and the fact that there's not equal rates of prescribing varenicline and the pervasive myths about that. That there are lower rates of lung cancer screening, despite, knowing that this is a vulnerable population with higher rates of lung cancer. And that extends to other types of cancer screening, particular more invasive types, like when we were thinking about a colonoscopy. And what about kind of delays to cancer diagnosis? We know that also is a factor, and that people are more likely to be diagnosed with later stage cancer. But even beyond that, even if we take all things being equal and people walk into the cancer center with the same stage disease, we also know that they are less likely to receive guideline concordant cancer care, less likely to receive guideline concordant radiation or breast conserving surgery versus a mastectomy, or complete their radiation. From there, we also know that individuals with serious mental illness, and particularly schizophrenia, are less likely to be referred to palliative care, more likely to die in a nursing home, and certainly excluded from clinical trials. If we were to extend this paradigm to cardiovascular disease, we know that, for example, after experiencing an MI, individuals with schizophrenia are less likely to receive post-operative beta block or falling like a calf, and that's regardless of having the same medical risk factors. So this is a lot of seemingly maybe not great news, but one of the pieces of good news here is we're learning on how we can intervene on these trajectories and therefore mitigate this cancer equity gap. And so we'll have some good news to come about how to do that and how involving mental health care earlier and having a person-centered strengths-based approach can help to mitigate these cancer disparities. At the level of the person, in terms of what are some of the things that impact this disparity, untreated psychiatric symptoms can certainly impact illness understanding of a new cancer or any new medical issue, or frankly, a psychiatric discussion as well, of course. What happens when there is uncertainty about understanding the seriousness of the cancer or what might happen if you don't get treatment? What happens if someone initially says no? How hard do people try to have that conversation again, to bring in other supports? And we can see here, this is the quotes from a mental health nurse. It's extremely difficult because she doesn't have insight into the risk if she doesn't get treatment. Person talking about the challenge of kind of persisting in treatment. What about for clinicians? We know that there's quantitative and qualitative data that shows that clinicians, whether they be clinicians in oncology or primary care or mental health clinicians, lack training that crosses disciplines and lack comfort and the time needed to care for individuals who have complex needs. These are the words from a medical oncologist. It's very easy for an oncologist to feel overwhelmed. We're not trained to talk about cancer with schizophrenia front and center. We certainly know that, as the Googling exercise showed us, and we certainly experience when we're trying to navigate the health system, that mental health care and the specialty medical care are fragmented. And that the reality is that psychosocial care remains inadequate, and that those disparities increase with more complex psychiatric needs, with Medicaid-based insurance, and we could go up and up and up. And even in an incredibly well-resourced state like Massachusetts, it's very difficult to find outpatient providers with expertise in, serious mental illness or schizophrenia and oncology who accept insurance. That is a very difficult thing to find. And I think that's the reality. One of the biggest barriers is lack of access to psychiatry. And with cancer care, we can't wait. Can't wait that 3 months, or it's not feasible, or it doesn't make sense to have the standard trajectory of care of initially seeing a therapist for an intake and then 2 months later seeing a psychiatrist. It just doesn't work in terms of the urgency of the cancer care trajectory when mental health needs or psychiatric illness may be impacting the person's ability to receive care right then. Finally, I think this is something that, a lot of people aren't aware of, that individuals with mental illness are systematically excluded from nearly 1/2 of clinical trials. When I talk with Harvard medical students, we say that's 1 in 4 Harvard medical students who would be excluded from a potentially life-saving clinical trial, as they can be in oncology care. And as this medical oncologist writes, there are people who falsely assume that patients can't give informed consent or won't understand. People kind of write off this population. So I don't know if that's been your experience in different settings in healthcare, or if people have thoughts about that. I think that's something that's important that we can keep, talking about. So I think this is the reality, right? And that's part of why we're here together, that mental health discrimination is pervasive. Brain illness often remains invisible, that people who are impacted by serious mental illness, by mental health disorders, the language that we want to use, often experience shame and isolation. And when you've experienced shame and isolation, that can contribute to delays in care, to preventable suffering, to death. That clinicians may feel helpless or unable to care for a population with complex needs. The more helpless we feel, the more likely our behavior is to reflect implicit biases. And that we just are not adequately investing in mental health services, training, or research. And because we don't include complex populations in clinical trials, we lack evidence to guide treatment. So one question becomes, how do you unlearn that helplessness? And how do you kind of deliver care differently? Even if it's not just going to be about, okay, let's have more psychiatrists and let's have more resources. What can we do in this moment that can really meaningfully impact that? In addition to including a broader team, what can we think about together that might change that paradigm? So I just wanted to give this example. This is Carmen, who has been a member of our community advisory board of our Engage Initiative, which is a coalition that's dedicated to ensuring that mental illness is never a barrier to cancer or palliative care, who also participated in our randomized trial of a collaborative care model, which we'll talk more about. What I want to highlight here, so she's an individual who identifies as sexual, as Latina, as having significant past trauma and depression, as being labeled as someone who misuses substances. And this is what she had to say, that doctors too can be prejudiced. Doctors need to listen more to the intuitive nature of their patients. White coats to me became a synonym with fear and distrust. I was to get a port to start my chemo. I was told it would be a quick, painless, same-day procedure. On the 5th day, I explained, it felt like an elephant was sitting on my chest. I called my doctor and they said, oh, it'll go away soon. On day 8, I went in crying to be seen urgently. I told them something's wrong. I can't bear this. Please take it out, please. They told me to bear it. They gave me a prescription for some oxys and they sent me home. On day 10, I went into cardiac failure. I contracted sepsis. It had spread through my heart and pulmonary emboli. I spent many days with no return calls as I lay sick in bed, unable to breathe and in pain. I was not able to think clearly. How was I supposed to be able to make life-saving decisions? I was on the phone to follow up. I realized they had forgotten all about me. The system is broken. I was just a number. I learned that when left in long periods of agony, fear, and stigma, that those can make even the most sane insane. So maybe I'll just stop for a minute just to see. I know everybody's probably, it's just me on screen, but just for a second, if anybody wanted to offer anything in the chat or say anything about that, I imagine some of those words resonate with people in the room or your experiences. I just wanted to take a minute to open it up for discussion before we go into further content.
I mean, I will say that does resonate with some things that I've heard people talk about insofar as either symptoms of medical illness being attributed to their mental illness, even in some cases, like if someone was having an allergic reaction to their medication for their mental illness, and that reaction was being attributed to the mental illness, and that same like, oh, it'll go away, like don't worry, like kind
Just
of
in your
brushing someone
head.
off. Yeah, and having to go to the emergency room like multiple times before having that taken seriously. So yeah, I mean, that definitely resonates.
And I think when people have a lot of medical issues going on at the same time, it's just really critically important to begin with the assumption that it's medical. You know, and I think Carmen is very articulate, as many people are who've experienced trauma, about knowing the changes in her body and describing them. And she had like 20,000 in a row experiences of those symptoms being disregarded and not being able to be heard. And so a lot of our role in the trial was advocacy for her at a physician-to-physician level so that her voice could be heard. But more to come on that. All right, so we'll go back. I'm not going to be insulted that no one has other, exciting ideas to offer. You can throw them in the chat. It's fine. All right, let's go. We'll see if I can manage to, again, share the slides. All right, I think so. I think we're back. So what do we do about that together? What's the hope with how we might mitigate that? What we try to do is apply a person-centered and strength-based lens to how we think about cancer care and research and advocacy that's related to this health disparity for individuals with serious mental illness. What have we done about that together? We developed and piloted a new model of care. We call it Bridge, person-centered collaborative care for individuals with serious mental illness and their caregivers, that we have developed in collaboration with community partners. And then we led the first randomized trial for this population, which examined the impact of this Bridge model on cancer outcomes. At the same time, we've tried to build systems that are sustainable to help to identify individuals with serious mental illness earlier so we can intervene effectively. And also think about how we can design for equity and co-design approaches in partnership with people who are living with mental health disorders. One example of that is modifying inclusion criteria or default inclusion criteria for clinical trials. We've also, in partnership with DMH and the National Alliance of Mental Illness, other stakeholders, American Cancer Society, Mass General, Dana-Farber, other folks, created the Engage Initiative, which is led by a community advisory board, which includes people with lived experience of mental illness and caregivers. Another name for that, that group of people is the Cancer and Mental Health Collaborative. It's a group of more than 1,000 people with some global reach now. And the goal of that is to create cross-sector partnerships and keep us centered on priorities that matter and build the infrastructure that can make it possible to do like community engaged research and also increase access to clinical care and education and training, so that, people don't just have access to this kind of a model at an academic cancer center, but hopefully we're also developing strategies to make this more of a standard of care for regardless of where you receive your care. And that's when we think about what does it mean to adapt a model for implementation and dissemination. We're thinking about how do we use technology to increase this reach of this model? How do we think about who can deliver this model? How are we partnering with peer specialists or navigators to deliver evidence-based interventions? How are we building capacity in community settings in partnership with people who live in the community to co-design approaches that can be sustained? Given like we're not going to magically have enough mental health care for everyone, how do we work in the context of the resources that we do and not lose the focus that if we don't talk about discrimination, that doesn't mean it's not there. So how are we going to bring that into the light in a way that doesn't increase shame, but also can, induce change, positive change forward?
Can I ask, you mentioned having some global reach with that group. Can you say, so I'm just thinking like how much of this is a US problem with like the health system we have, the health resources we have, and how does that look like in other countries that you've seen?
Yeah, so I mean, I think this is not only a US problem, which is interesting, right? Because even in countries that have a national health service that have universal health coverage, like the UK or Ireland or Australia or Denmark, we still see this pervasive health disparity in the 15 to 20, 25 to 30-year mortality gap. And so it's when I was talking about kind of like this double disparity, this idea that it's not just about socioeconomic barriers, it's also about like the unique experience of having a mental health disorder. And it's not just about like, sometimes a really good follow-up question is like, okay, well, how much of this is because of being on atypical antipsychotics? Well, here's an interesting fact, people who are on clozapine actually have better life expectancy, than people who don't. I think all of these factors are important, but we often find, I think a lot of the dialogue is focused on, oh, well, there's such a high rate of smoking. Everybody's developing metabolic syndrome. It's from the meds. Or even it's from like poverty-related barriers that as healthcare clinicians, we may feel less able to directly influence. And that can lead to feeling kind of helpless. So I like to try to recenter. I'm just saying in the room, we know clinicians are more likely to make a decision that is less likely to be consistent with standard of care. And that is something that we can influence. And that earlier involvement in mental health care and a team-based approach actually changes that. And that saves lives. So I think it's really interesting, though, that there's really a movement in so the Irish Cancer Society and some folks in Denmark are actually transforming their health system. And some of the principles of this model are guiding that, which is kind of exciting to think about like transforming things on a national level, which like in the United States, it's like doesn't work that way with our health system, but it sort of does in other countries. Like they set a precedent and they like have a policy and it matters in terms of what healthcare looks like. I feel for us, like policy is so far away from what guides clinical practice at a hospital level, but it's much closer in the context of a national health system. So thanks for that question.
Yeah, so I also just think, it's so helpful and important that like these issues can feel very big and like you said, like kind of untouchable. So finding the places that you can affect or the things that can be moved is really helpful.
Yeah, I think absolutely. I think whenever any of us feel helpless, like you just kind of shut off. And it's harder to take action. And I think that's the thing, that's a way to talk about it that clinicians can relate to, as opposed to being like, hey, you're prejudiced or you're biased. it's all true. It's kind of finding, like, because we all are, that's human nature, and based on our experience. And of course, I'm kind of like, if I ever talk about that, I'm like, so I took the unconscious bias test. Here's what I think. Here's what happened to me, and that can be a way to open up the dialogue too, but it does happen. We'll talk a little bit more about that. So here's just some examples that are a little more specific to common language that's used in the context of mental health and cancer. I think for me, the guidelines that you guys provided earlier are really helpful. I've also found it helpful to try to be as specific with language as I can and when describing. And so that's one reason I don't love serious mental illness as a term. I'm open to, like, what does that mean? The other ones aren't serious. Like, it's just not a good term. And I don't have perfect language to encompass schizophrenia, bipolar disorder, severe major depression that impacts functioning. But I'm open to suggestions. But I think some of these are really important and are pervasively utilized in the medical record, and pervasively used in meetings, in academic meetings. I think I did one day where I just counted the times that language was used in the context of just my day that I wouldn't be consistent with this guidelines, like 15 times. It really does add up. So I think for me, some of the ones that were a little bit, like, if I hadn't thought about it before, it was helpful for me. It's a process of continuing to notice our language. I think that I'll notice a lot of casual conversations amongst, for example, my children and their friends, and just in casual conversations, oftentimes people, and especially work meetings, oh, that's so OCD, or that's so crazy, right? And it said very casually. And so unpacking that a little bit about why I feel that perpetuates a stereotype of what it means to live with that illness, and how that might be different from that person's experience, and how it's also not accurate to describe the experience that you're talking about, and thinking together about what might be language that actually just reflects your experience and doesn't pathologize or, a disorder, which is like causing a lot of suffering, or can't, I think even in our own note templates, we notice, like, using like chief complaint, like, why are we saying that? Like, that's just like, it's really, it's people's complaint. And that's a default template for most medical notes. I mean, I think no-show is another concept where one of my colleagues writes a lot about this, that really it's a missed care opportunity, but who is the responsibility on to get to that appointment? This isn't like a restaurant. And if people have a disability, it makes it impossible to arrive at 7:30 in the morning on a Tuesday. We need to accommodate that disability, just like we would accommodate someone who had a physical disability that meant they couldn't climb stairs. And why are we labeling people difficult or non-compliant or refuse? This happens all the time. My personal favorite is, like, when people tell me someone's lovely. Okay. I don't know if anybody else is like a psychiatrist in the room, but that is, like, first of all, like, why do they need to tell me they're lovely? And also, usually they're speaking in an opposite way to tell me that their experience is perhaps not that. So I just think we can be more specific. Anyway, so what's an example of this that's important in terms of thinking about helplessness? What can change when we think about someone's strengths? So I want to tell you a story about someone who was referred to our first pilot. So he's a gentleman who, lives in Chelsea. He had come to the United States in his teens. He was in a long-term relationship with an older male who was quite supportive to him. Let me tell you how this was first presented to me. So this is this gentleman, we're not sure what we're going to do. He's in his 40s. His psychosis is so severe, he got kicked off the bus. He hears voices telling him to kill himself all the time. He's drinking 9 to 12 beers per day. He uses cocaine intermittently. He's yelling. He doesn't call us back. There's going to be delays. He goes off his meds all the time. And now he has this new rectal cancer. And I don't know what the heck we're going to do about this. What do you think, Dr. Irwin? So that's one way to present a case. And I would say, okay, gosh, I think to most people, now this is my area of expertise, right? So I'm not going to say, though most people would, I don't have the expertise in uncontrolled, untreated schizoaffective disorder, plus rectal cancer, plus substance use disorder, plus challenges with the police, plus lack of access to care, plus won't let a visiting nurse. Oh my gosh, right? Are we feeling like that could be a challenge? And that there may not be a simple solution forward. So I think it's just interesting. I'm going to tell you another version of the story. This gentleman had worked at the airport for more than 10 years. He'd been in a long-term relationship. He has a therapist and psychiatrist. He came to our appointment on time in a collared shirt. He spoke 2 languages fluently. He was very engaged, polite, expressed interest in coming back to the cancer center, was interested in research, had some strengths as well. And so I think that the reason this matters is that what I tell myself is the more hopeless I feel as a clinician, the more I need to stop and ask about someone's strengths. It can be incredibly disarming. Has a doctor ever asked you like what you're good at, what your strengths are? I didn't learn to ask that, but I have, and it has changed my care delivery paradigm. And I think it means something to people. And oftentimes it's quite moving because people can't name something, or they can, and they pause on it for a minute and remember something about them that's not about being a patient and being sick with cancer and having uncontrolled symptoms. They're able to articulate something. And so for this person in the room, you wonder, like, well, what's the intervention, Dr. Irwin, that mattered here? What did you do? He had a psychiatrist in our system who's a good friend of mine, colleague. He had very good clinicians who cared about him. Was it going to be some magical medication adjustment that was going to make the difference here? I'm not saying that we didn't think about delivering his chemotherapy in the hospital. We did. We provided education. I did provide some guidance on that, but that was not the fundamental intervention. It was actually asking him to go for a walk with me, to go to the healing garden in the cancer center, because I think that fundamentally, as he left Chelsea and came into Boston in this new cancer center, I think he was most worried about not being respected. As he came into the room, very well dressed and presenting, and he knows his history. And and many people would have said, like, don't, how would you dare approach him for a research trial? He's never going to do it. Well, that's the assumption oftentimes we make. That wasn't my experience. He was very interested in doing research and partnering with us in that effort. He completed our pilot study, and he completed his radiation for his curative rectal cancer. There were challenges along the way. There was a lot of partnership with home-based nurse. There was a need for him to come into the hospital, a lot of education about the oncology nursing staff about when to worry and when not to. But he completed his radiation and got through it, and did so in a safe enough way to get to the other side, and was very grateful to have participated in the research trial. And I think that was something that he was really interested in and wanting to contribute to, and helped him feel some purpose. So, I mean, that's my story about strengths-based language, because I think we throw out these words like person-centered and strengths-based, and it's not always clear to me what that means. So I mean, thinking about the person, not just in terms of like why they're sick, and talking about what they're good at and what their family and strengths are and how they've coped with hard shit in the past. The reality is, like, many of the people we care for, that's a strength. They've had, in fact, more than one person has said to me, cancer is the best thing that ever happened to me. I finally got connected to care. My family finally cares about me. It's obviously not true for everyone, but it is sadly sometimes true because of the different way in which we think about causative models of schizophrenia and cancer in our society. So in terms of the hopefulness question, I said we're going to get to some hope, promise some hope. The good news here is that access to psychiatric treatment at the time of cancer diagnosis actually promotes equitable care for individuals with schizophrenia. You have the May language in there, but we just did a randomized trial, so I can tell you, yes, it does. So we'll get to that. And that's good news, because that's actually something we can do as a health system. So yes, maybe, well, I don't know. Does anybody want to say anything in the chat? That's fine. I can keep talking to Kelsey. I wondered if any questions had come up for anybody. So this is Jonathan and his mom. And they're really two of the patients who really inspired the development of our particular person-centered model. I met Jonathan when I was working as a psychiatrist in the cancer center, and he's a person who had been hospitalized repeatedly for worsening psychiatric symptoms in the context of his colorectal cancer. He was 44 at the time he was diagnosed. He had been in and out of the hospital with worsening pain and a cycle of worsening pain and worsening beliefs about being harmed and not wanting to take medication. And, shockingly, he never made it to his scheduled outpatient appointment. I mean, there's a shocker. When you feel that sick and like everybody's out to get you, is it going to be a priority to go to an appointment? No, it hadn't worked a couple of times. So I was like, all right, we're going to try something different. So I walked over to infusion and I saw him there. And at first he wasn't super excited about seeing me, but with some accompaniment and a lot of partnership with his mom, he was. And we were able to adjust his medications and have him be in a place of thinking more clearly. Unfortunately, his cancer did progress. But at that time, his thought process was clear. And he was able to have a dignified death in the hospital. And after many years of advocating for her son, his mom said something to me, which I have 3 daughters, I think is still something that really grounds my work. She said, I could finally stop being his caregiver and start being his mom. And so when we think about this isn't just about cancer care, but just about the human right to a dignified death, it's one thing to die. It's another thing to die with uncontrolled psychotic symptoms, if that's preventable. And that's something that is something we can do something about. And so sometimes when we think about what matters, to me, that's so fundamentally important and something that we can do something about. And by bridging care with hospice and building things like coalitions, we can get closer to that. And it's not just older adults who that affects. Younger adults get cancer too. And so it's something to think about, across ages. All right, so this is our model. It's called Bridge because of the connections that we make. It's called person-centered because, as I said, we're grounded in not just the patient, but that whole person and what matters to them. And also thinking about who their caregiver is. Often for many individuals with schizophrenia, they may not be married. It may be a family member, be a sibling, a parent, a child. It could also be a frontline staff member in a group living environment who's really advocating for them as their main support. So all of those are caregivers in our model. And the goal is that with a person and caregiver at the center, we have an approach where the mental health team and the oncology team together develop a joint plan for their cancer and mental health treatment. And that person is also linked to a social work case manager or navigator. It could be someone else, depending on the staffing available, who addresses resource-related barriers to care, and that we accompany them through treatment with the goal of them, getting cancer care delivery that they need. All collaborative care models, the collaborative care is an evidence-based model, which we know increases the reach of psychiatry care in primary care settings and also in oncology care settings. Collaborative care has some basic principles. It's population-based. So we use a registry that uses an algorithm through the electronic health record to identify people proactively at the time of cancer diagnosis. We had to build that just because mental illness is not always cared for in the same system as cancer care. We also collaborate with our colleagues in our coalition to get referrals from our colleagues at North Suffolk or Big Cove or VinFen or other places to ensure that we're not missing people who may not have gotten to specialty cancer care. It's team-based, meaning it's uses a social worker, case manager, and a psychiatrist who partner with the oncology team. And we also bridge with community mental health care team, to kind of think about who is that broader team. It's, when we think about it being person-centered, we accompany people across care settings or do our best to do so. And collaborative care models are also what's called treatment to target. So, we measure evidence-based benchmarks like the Patient Health Questionnaire 9 for depression or the Generalized Anxiety Disorder 7 for anxiety, or a measure of psychiatric illness severity, and also track whether or not people are getting evidence-based cancer care. And if people are not, we intervene early to change that and measure the progress. And so the goal is increased access to evidence-based care. And by integrating that into an oncology care team, we use the resource of psychiatry more efficiently by partnering with a social work case manager and navigator in the oncology team. So I think what's innovative about our model, just briefly, is people have done a lot of collaborative care models, but have never been adapted for both serious mental illness and a new cancer diagnosis. So it's acuity times acuity. So that's what kind of makes our model different in terms of you have a little bit more upfront access to specialty care, and we're able to kind of rapidly pivot. And we also do joint visits with oncology. Thinking more broadly about research, we know that this population has been excluded from clinical trials. We also know that there's been a lot of coercion in clinical research for individuals living with mental health disorders, particularly other marginalized populations, people cared for in the forensic system, people from racial and ethnic minorities. So how are we going to respond to that? Oftentimes we talk a lot about protecting people from research. That's critically important, but excluding people from research is not protecting them. And I think we need to think about how we can change how we do research to be more inclusive. So like a 12 to 15 page document for informed consent with a bunch of legalese makes sense to no one. It's particularly challenging if you may have difficulty processing language, or difficulty or experiences or worries about being persecuted at any time, like any written document and legal stuff. So is that really the best way to build understanding of a clinical trial? No. I mean, it would be much better to have multiple conversations and to use a verbal consent process using concrete examples and repetition. And we can check on understanding, using something like an assessment of capacity to participate. So the goal is to build understanding so that more people can show that they're able to participate in clinical research. And we can address some of these structural discrimination barriers by designing our research trials up front in partnership with community partners, including people with lived experience and people from different organizations that are affected by this. And we actually have clinicians assess capacity to consent to make sure that people have full understanding, any mental health clinician, and really think about this fragmentation and how we can accompany people across this current trajectory and use any opportunity for where people access care as a potential place we can engage people, whether that be a home visit, whether it be a community mental health clinic, whether that be chemotherapy suite. This can be challenging in the context of limited time and staffing, but it is absolutely what people need. Also, it's really helpful to communicate by text. Why? Because that's how people communicate. So it decreases a lot of barriers of calling back and being flexible about that, giving people multiple ways to communicate between sessions and trying to decrease barriers to communication is another thing that people really value. So the first study that we did was just a feasibility pilot. I can tell you that many people told me that we don't care for people with schizophrenia and bipolar disorder at Mass General Cancer Center. Of course, I knew that not to be the case, but it's what many people told me. They also told me that nobody would do research. They wouldn't be able to complete the trial, that I was setting myself up to fail. That this was just too extreme. What was I thinking? Just sharing. These are some of the common paradigms that happen when you're trying to do something that's a little bit different. This is a new model. It's a population that hadn't been previously included in cancer clinical trials or psychiatric trials, really the combination. So was it going to work? It was really the first step was trying to figure out whether it was feasible to do this 12-week intervention and collect self-report measures and also have clinician assessments and, really meaningfully be engaged in their cancer care delivery. So our goal was to enroll 30 people in 15 months, and we did it in 4. 90% of the patients consented. 100% had their assessment. 88% completed the self-reports. Most importantly, 6 of the people who'd been referred hadn't gotten the cancer care that they needed. 5 of 6 got everything that had been recommended, and everybody received more of the cancer treatment than they had previously. And I don't mean to say that it's not okay to ever decline cancer care. What I mean is this is like guideline concordant standard care that at times had not been offered to people, or people thought that they were not stable enough to receive, and they were able to receive that through the care that they received in the trial. So as Adi says here, her past experience, I didn't feel wanted. I had a lump for 6 months. I could feel the team dismissing me. The team listened. And that was the difference between life and death. When I first met Adi, actually, I was paged to help with her transportation in the OR. So, I mean, it's not a page. It's an interesting one, right? Oh, I'm getting paged to come to the OR for transportation. A lot of people might say, hey, well, I'm not the transportation person. And I can understand where that comes from. Everybody is busy, right? But that was the key barrier that was preventing her from being able to go home from her surgery. And so we had to problem solve around that. And there was something there where we had to figure out also, okay, this person wasn't getting their lithium. They had cognitive limitations that were making it hard to know whether they were receiving. They need home-based nursing. We need to figure this out. So she valued the experience of being treated with dignity. Caregivers valued the joint expertise in mental illness and cancer at the same time. And oncologists also valued that, that psychiatry is available, you can partner with them, and that made it possible to deliver care. And then, all right, we're about to do this randomized trial, and then this pandemic happens, so that might make things a little bit more challenging. We know that if we keep doing things the same way, that worsens disparities. We know and witnessed that many preventable deaths for individuals living with mental health disorders during the pandemic, particularly older adults living in nursing facilities, but also in group living environments and also people living at home. These are some of the quotes from, individuals who were involved in our coalition at that time. One of my former patients who had been living in a nursing home for a long time. Sometimes I think it's just a matter of time. I see more bodies coming in and going out, being tested by God. I'm worried clinicians don't have time. People are falling through the cracks. I worry about people dying alone. Not everyone has broadband or the internet. I feel like I'm failing at everything I do. So we had convened a community of practice, really focused on older adults and also particularly Latino adults and those living in group living environments with complex needs, to think about kind of how might we do things differently to increase access to telehealth and virtual care in research and in clinical care. What were the barriers we might unpack, and how are we going to do things differently, particularly to reach older adults affected by mental health disorders from marginalized populations. This is some of the qualitative work that we did in terms of the barriers to technology, the loss of ability to go to to a day program, and what's happened. And here we are 3 years out, people are still not going. Because it's really hard to initiate something after you haven't done it for 2 years, and things really haven't gone back to the way they were before. And so I think this was a really exciting kind of research methodology to think about, and just pragmatic approach to problem solve together, to create a community of practice, a group of people who care about something, who get better at that by doing it together. So who did we bring together for this work? Mental health clinicians, navigators, community health workers, peer specialists, mental health advocates. You kind of see there in the middle, and created a virtual collaborative where we used co-learning principles to educate each other about how we might do this work differently, and what were the barriers to research and kind of best practices going forward to close the digital divide gap that was making it challenging for people to participate in care and in research, and would only worsen without new approaches. So these are some kind of guidelines that were developed by our, the groups that we convened together. And I think sometimes also, I think it's important, the pandemic also presented opportunities. Disruption always presents opportunities. It's just what we do with them. But if we don't do something differently, then it's not going to, get better. But we did have the opportunity to think there were new approaches to telehealth. There was more broadband than there had been before. There was more comfort with asking why not. People were just doing whatever because you had to do something. That spirit of innovation was important to leverage. But we weren't able to do in-person visits in the same way. Caregivers weren't in person in the same way. So what do we do about that in terms of thinking about how to, increase access to technology? I think one of the key lessons learned is not rocket science. Ask people which technology they prefer. Try to tailor your approach to that technology. Try to figure out some reason people use that technology that's not just going to the doctor. They're more likely to practice it. So could they use it to talk to their granddaughter or go to the bank or whatever, play video games? I don't know, but something that's not about just going to the doctor. That will help us be more sustainable with how we're learning a technology and continuing to use it, and how we're partnering within the community to kind of make that happen. And just being transparent to start with, that's great that we have pivoted to 95% telehealth, but only 10% of the people I serve have that platform, just FYI. So who's closing that gap? What time is being accounted for that? What's happening there? We have to say that out loud as a first step, I think. So this is the randomized trial that we did as a follow-up to the pilot. A randomized trial of person-centered collaborative care for individuals with serious mental illness, including schizophrenia, bipolar disorder, severe major depression, at the time of cancer diagnosis, cancers that could be treated with curative intent. You can see there in the inclusion criteria, we also enrolled caregivers. We randomized 120 patients, either to our bridge model that we've talked about, or to enhanced usual care, which included proactive identification and linking people to making sure people were aware of psychosocial resources, and the oncologist was aware of their psychiatric diagnosis. And one thing that was innovative about this trial is that our primary outcome, was whether or not they had a clinically meaningful disruption in their cancer care that would be associated with survival or quality of life. So they have a clinically significant delay or deviation from what they should have gotten, or interruption in planned treatment. That was really our primary focus with our work. We also measured psychiatric illness severity using the brief psychiatric rating scale, but that's what's new about kind of this approach. So could we do it? Could we do it during, the pandemic happened like kind of a third of the way through? we were able to pivot and deliver the intervention virtually with a lot of kind of flexibility and to meet our accrual goals. So it was certainly faster prior to the pandemic. So we enrolled 120 patients in 30 months. 83% of our eligible patients consented to the randomized trial and 91% of caregivers. It's different to think about consenting to a randomized trial as opposed to like a single arm trial where everybody's doing the interventions. It's interesting how little bandwidth people had during the pandemic to answer the phone. And what are the strategies to help people think about how this might be helpful or how you might be contributing to research and be a partner in this work together. Harder to do that on the phone. So how do you figure that out together and who do you partner with? So who is the population we enrolled? I think this is important. Sometimes people one of the things I'm a big advocate for is that SMI or serious mental illness needs to be a disparities population. And right now it's not, which means that grants focused on this don't have independent funding, but look at the level of socioeconomic disparity here. And that's not even mapping on the pervasive mental health discrimination we've already discussed. So in terms of like the proportion who ever lacked housing, 25%, unemployed due to disability, more than a third, the education variance there, the income, this doesn't surprise probably people in this room. It very much surprises the oncology audience when I talk about this with them, that this is the level of poverty and the different kind of like living situation that people are coming from, in addition to challenges like with health literacy or transportation. And then also we asked about the experience of discrimination in healthcare settings. You can see, did a doctor or nurse act like they were better than you or act like they were scared of you? We also see that 39% of people were current smokers. Another 39% were former smokers. 46% had an alcohol or opioid use disorder at the time of baseline. These numbers are significantly higher. The rate of smoking amongst other, like for example, our breast cancer population at Mass General Cancer Center is more like 5%. Now, obviously, there's a rate of smoking is higher in head and neck cancer and lung cancer, but nowhere near 40%. And so this is also something that's a really modifiable factor that people, with education can really help us to address. All right, so hey, you don't have to be motivated to quit to benefit from varenicline. It's safe in most people who have, reasonably controlled illness. Give it a shot. And it makes you more than 5 times more likely to quit. It also works better when kind of combined with tobacco cessation counseling, but just to know that medications alone will increase your rate of quitting by 5 times, it's important to know. And that we just have a lot of assumptions and myths about it. So, a pretty reasonable distribution of cancer types and SMI diagnoses. So what's the take home? In terms of our primary outcome, we found that people in the bridge model had half the rate of cancer care disruptions. These were evaluated by a blinded panel of specialty oncologists who didn't know which arm the people were on, and it was a very rigorous process of thinking about, is this really something that would impact their survival or their quality of life in the context of their cancer care? So to know that decreased by half is a really powerful signal of what early mental health involvement and a team-based approach might do in terms of a cancer care trajectory. You could think about future trials showing also a benefit in terms of cancer survival. In terms of feedback from oncologists, you can see like they felt that it impacted the patient's care, it impacted them as oncologists, and patients and caregivers and mental health clinicians talked about the impact differently too. It also improved psychiatric illness severity, assessed by like the brief psychiatric rating scale, decreased anxiety, a clinical global impression is what the CGI is, just like how sick is this person in the context of like knowing other people with this diagnosis, and that got better too. The level of depression did not decrease significantly. This is a really heterogeneous population, multiple diagnoses, multiple cancer care trajectory. It's really hard to find a signal like that. So to see this is a powerful sign that, there was movement in terms of anxiety and illness severity. People found it helpful, both people who identify as patients, caregivers, and oncology clinicians. I think just for a moment, this might be, I don't 100% know who's in the room, but I think this might be relevant for folks that for mental health clinicians working in the community, how did it help them? So us communicating with mental health clinicians and helping to bridge this care gap with specialty medical care. This is what people said about that when we did exit interviews with mental health clinicians after, that it was a critical bridge for communication. It was so different to have a team and to be able to have open conversations and provide updates in real time, that it greatly increased my understanding of my patient's cancer treatment, prognosis, diagnosis. It's very helpful, to have that additional psychiatric expertise and awareness. that it helped my patient to have more illness understanding of their cancer, to break down the options for treatment in a way that was comprehensive, but also easily understood. For someone living with chronic mental illness, it was person-centered and at the level she could understand, while still being comprehensive for the necessary parts, the risks and benefits of treatment. More knowledge, understanding, and empathy, breaking things down, being able to work together to make sure that the person had all the tools available to make these life-changing decisions. What about, patients' words, caregivers' words, what really helped them? Maybe sometimes it was something really critically important and practical, like getting the ride, getting transportation. Maybe it was helping to quit smoking. Maybe it was reaching out to a caregiver. Maybe it was providing space and time to process the emotional and psychological impact of cancer. And I would say not only that, and oftentimes it was also adjusting medications. Some people had a psychiatrist when they came in, some people didn't. It varied. This idea that what people need, it differs based on what they're going through, and addressing kind of that as a full person. So back to Carmen. I just remember Carmen from the beginning. I remember her. She's doing okay. So one day I received a call that changed my life. I finally found someone that believed me. I didn't have to prove I wasn't a drug addict. I was made to feel that my pain was imaginary. Or better yet, that because of my tattoos, piercings, and the color of my skin, I wanted to exploit the system. I'm a proud, educated Latina, and my complaints fell on deaf ears. I now know the truth, and walking away has never been an option for me. My community is suffering and being left behind due to the lack of personal or systematic education, language barriers, awareness of my rights, or affordability in the medical field. And what she said to me was, no one believed me. You believed me. Every time I wrote you and told you what was happening, even though it wasn't your job, you wrote the 5-10 people that you needed to write to make sure that what happened happened. I never had someone advocate for me before in that way. And that, was really critical to saving my life. And I think just dignity, affirming to the save your belief in the fact that anybody gives a shit about you, right? So a lot of intersectionality with levels of discrimination here that are not isolated only to a past experience of trauma or an experience of substance use, but also to being LGBTQ and the way you present yourself and your appearance. And just for me, sometimes, I forget. I see people in the hospital often, or they have cancer and they kind of look sick. And you don't always know what they looked like before. And so when Carmen shared her story as part of our coalition, we often have events that include that. This is a picture she shared. And I think this is just important. I don't always do that. It reminded me, what did you look like before? What do you actually look like in real life? How far away is that from who's in front of me right now in a moment of extreme suffering and illness? Just to remember that it's probably not them on their, feeling best day. So what do we do? I think we do need more of these bridges that we're trying to create, person-centered care across settings. There's lots of examples of this, about not needing an appointment for a mammogram, about psychiatric nurse practitioners prescribing varenicline, about lung screening decision-making happening in a clozapine clinic, about adapting telepsychiatry models. One of the things that we're working on is people might have heard of a cancer tumor board. Traditionally, that is focused on the biology of the tumor. So you can see on the left, it's someone with hepatocellular carcinoma. So we have our pathologist, we have our radiation oncologist, our medical oncologist, our surgeon, our hepatologist, palliative care, and maybe there's a social worker who's kind of off on the other side. Developing a plan. What would happen if, rather than the biology of the tumor at the center, we had the person and the caregiver at the center? And we included a navigator, a community health worker, or a peer specialist, and a psychiatrist, and a community mental health team, and the medical radiation and surgical oncologist. How would that change the dialogue about, what kind of a plan we're creating together? So that's something that we're piloting in partnership with Elliott Community Health Services and the Danvers service on the North Shore. That we're excited about as a way to increase the reach of a model that can be delivered virtually, and to build the expertise of practitioners in the community to deliver care for people with complex needs. I think this is really important. We're going to need to use virtual models to build capacity for psycho-oncology care and to address barriers to care. And even at this level, what are the strengths of the community? What do people in the community get that folks in a specialty medical center may not understand about kind of resources in the community? Who can we bring in? Who's the cool shelter staff that I don't know about? There's a lot of places in the community, even during COVID, I hadn't spent a lot of time in my community. You kind of spend more time. So I'm all right, who's in Concord that does stuff? There's people who do stuff. I didn't know, but like people know, or who goes to the library, like who's working at the Starbucks, who are the people who care about this? How can we bring those people together to have a shared approach? And I think just bridging communication, particularly between community mental health agencies and specialty medical care, was critically important because they were often caring for the same people in very fragmented ways. And it was, just very helpful to break down that barrier. And I think that there's a power in that they can then refer patients to each other, and can learn to address kind of the needs of people who need psycho-oncology care and navigation in community settings. So that's kind of what we're investigating right now in this pilot study. The model, again, uses like the spirit of co-learning. So it's collaborative case discussion. It's not like me talking at people, it's people, presenting cases and share a dialogue. Maybe a nurse practitioner talks about, changing clozapine for someone who's on cancer, how it affects her, quitting smoking affects her clozapine level. Maybe someone's talking about like building rapport in the context of someone who had past trauma. Maybe someone's talking about like, okay, how long do I really have before I need to start head and neck cancer treatment? What does it really mean to have palliative chemotherapy versus curative care therapy? What's immunotherapy? We could go on and on. What is hospice versus palliative care? Like, what are the resources in the community? And that we identify people with both our population-based registry, but also encourage referrals from all the people who participate in our tumor board. We're also measuring the impact on people who participate in the tumor board. How does it affect your experience of resiliency and burnout caring for this population? How does it impact your self-efficacy in being able to care for this population, which would counteract that feeling of helplessness we discussed previously? This is our coalition. The Engage Initiative or Cancer and Mental Health Collaborative. Certainly invite all of you guys to join us, or people. We try to engage, diverse voices to promote equity in cancer care, palliative care, research for people impacted by mental illness. Is the words that our community advisory board chose. It's important to them and to me to say serious mental illness, because this wasn't about wellness and mental health. This was about the disparities experienced by people living with mental health disorders. But I'm here to listen to other people's feedback on that language. And at the end of the day, like, it's not just bridges, right? Like, maybe other people are not as inspired by this as I am, but I think this is a really interesting concept. This idea that it's not just about bridges, but that there's these complex networks. Have you read about like the fungi underneath the forest and how like what makes an old growth forest grow? Whereas if you take all those trees out and you just plant them in an isolated way, they all die. It's not just enough to replant a sole tree. What gets lost is this complex network of roots underneath the soil. That's really strengthening everything. So what I would say is we don't just need bridges. We need these strong networks to nurture the collaborative together. So I don't know if that speaks to you, but I like that image, and it helps me remember kind of what we're trying to build together. And my coalition building is so important. So this is our pledge. Feel free, you can take it. I'll take it again to remind myself by giving this talk on Friday. I pledge to ensure that mental illness is never a barrier to cancer care. So certainly you can check out our website if you have a patient or person who you can't get cancer care for, or mental health is impacting, that you can reach out to us, to me. Personally, and I'm happy to help problem solve. I do consultation with DMH, and I'm always happy to try to help anyway. So what's the take home? So for a minute before we kind of open it up for conversation, we know that individuals with serious mental illness experience premature cancer mortality due to inequities in cancer treatment. Let's make that bigger. We know that people living with serious mental illness experience premature mortality. They die earlier because of inequities in healthcare. We know that we can come up with models where we connect people earlier to proactive psychiatry consultation and involvement of a broader mental health team. We know that that's feasible, that it's acceptable, that it impacts cancer care delivery. We know that with adaptive trial procedures, people with serious mental illness can participate in clinical trials. We have to change exclusion criteria due to mental health disorders that is causing preventable death. Randomized trials and community engagement are needed to advance equity in healthcare and research. In addition to raising awareness of the need to classify this population as a disparities population. For all of us, like what helps keep me motivated and not burn out? Well, like, I think be transparent. Say what's actually happening. Don't pretend something's happening when it's not. Keep it real about like what teams we might build together, and thinking about people as like people. Be flexible, pragmatic with how you're thinking about technology. Good way to do that is to check with yourself, like, how do I actually use technology in my real life? Would I want to do this? Is it helpful to me? No? Okay, what might I try instead? Not that it's always the same, but there's a range of options.
How do we build these kind of communities of practice beyond the health system or beyond a siloed part of the health system? How do we adapt evidence-based models guided by implementation science and health equity frameworks and really keep human rights, social justice at the center? So this is like my thank you to many of our collaborators, to all of you guys as well, for being part of this work. It's been hard work. It continues to be. It's really hard work to get funding for. And so one of the things that matters is to know that there's a community of people who share a commitment to this work that helps keep me doing the work. So I appreciate that all of you are here. These are my children. They're bigger now, but they keep me inspired as well. And then I thought I'd break it. I was told an hour and a half, so it's 12:37. So I have some clinical case discussion if we want to, or we can stop. You know, these are my pearls, right? So like engage an ally, find common ground as a human. Don't get lost in autonomy without early examining if it just means you just care about the person's life less. Acknowledge what you don't know. Question HIPAA. HIPAA is supposed to facilitate clinical care. You are supposed to break the glass if you're on the care team. That's your job. Sorry, it means that you feel like you might get sued, but that's actually what you're supposed to do. It's a flaw in the way the system is designed. We can talk more about that. Wonder about doing a home visit, you know, in a way where you're supported to do that safely at a key clinical turning point, and what might that open up? From a medication standpoint, think about choosing medications that have minimal interactions with chemotherapy. You know, don't stop people's colostomy without talking to their psychiatrist. You know, even if someone declines psychiatry, the conversation doesn't need to stop there. It doesn't stop there when someone needs to see a nephrologist or cardiologist. That's not the question. People don't always know what medical issue might be impacting their ability to survive. We need to think differently about those paradigms, I think, and think about who your team could be. So I'm going to stop there and open it up for conversation.
Thank you so much. I want to say that your fungi example really gels with me, especially, I mean, MapNet is another one of those networks, I think. So I really appreciate that.
I got a little bit of like, I think the last person I said this, they didn't really get it. I think they were like, what? And I was like, oh, like the fungi. I think I know Zaray from back in the day. Did you have a question?
Yeah.
Hi, Kelly.
Hi, it's nice to see you.
It's nice to see you too. I am homesick so I'm not in meetings, and so I wanted to hear sort of, you know, I have, I guess, maybe a question or a comment, because, you know, now I work in Bedford, and it sometimes feels like we are more disconnected from kind of the things that are happening. And I'm wondering what kind of an opportunity some of us who are not right inside the Boston area might have to connect or educate. I'm a little disappointed I don't see other folks from the same organization today, because there's so much opportunity for us to be collaborating. And so what would be sort of an option? I work at Edinburgh. Yep.
Edinburgh, yeah. So I mean, as I might have mentioned, I'm in Congress. We're close by. We're collaborators. We're net neighbors. So there's actually like a lot of opportunities to collaborate, because we actually are doing work across the MGH Cancer Center network, which includes a catchment area that includes like Emerson Hospital, Danvers, and many of our patients come from the shared community. And we also think about serving the state as a whole. So I've done things in partnership with folks at Edinburgh back in the trial where we did home visits at the group home level together. I think that certainly would be wonderful to think more together about what the needs and crossover is. I think you know, one of the conversations that I have is around, you know, what the priorities are. And I think there's some innovative ways to work on cancer screening and also access to palliative care. But we're also talking about kind of extending that cancer and mental health tumor board model to involve, like, you know, people, clinicians, frontline staff, folks from community mental health agencies who want to build some expertise in caring for this population and navigating everything from how do I address tobacco cessation and cancer screening through to how do I get my person into acute medical care to how do I think about the end of life. So I think that's another opportunity to participate in a cancer and mental health tumor board if people are interested in that. I think that's one way. I think also just thinking about the population you serve or work with and what's happening. We found a lot of people were aging in place and no longer able to stay in their group living environment. That was a huge challenge. That's another thing that's a big crossover in terms of what happens next and how can we can accompany people through that. What happens to people when they go to skilled nursing? What ensues from there in the context of limited resources. But I think there's a lot of opportunity to collaborate, and particularly for me, because I happen to live close to you, we are going to be doing more, I think, work at Emerson Hospital, which is a cancer site for MGH. They have radiation oncology there. So we do work there, but I think we also serve a lot of people who are served by Edinburgh. So I think there's opportunity.
Okay. I'll reach out.
Excellent. I would love
Thank
that.
you, Kelly. I appreciate it.
I'm in fact hiring if anybody wants to know. I'm going to just take a minute since I'm here. A half-time navigator. And we'll also be looking for probably some social work help too. And we're also thinking, I don't know if any of you guys know Amy Sika. She's a good friend of mine who's at Riverside. We're thinking about how to, involve peer specialists in our model going forward. I know something that's close to your heart too, is right. So I'm open to talking about that too. And I think resources are limited, but creativity abounds. So there are ways in which we can work together that are helpful. And I'm always happy to chat about that.
I'm open to talking about anything that with you.
Yeah.
Will that social work position be full-time or part-time?
Half, it's like 32 hours right now. I think the social work position.
Okay. Thank you.
Thanks, Ray. I'll follow up too.
I wanted to just bring up or even maybe mention this idea of so you have talked a lot about making sure people are getting the best like standard of care, and thinking about our programs, a lot of them really focusing on prevention and early intervention, primarily for mental illness, but how can you speak a little bit more to the like prevention and screening side of things? Because that's it strikes me as, a population that is not yet in that system.
Right.
Yeah.
So I think that's a really good question. I mean, I think like there's even in like the context of like a first episode clinic, right? How might I think about this? So we talk a lot about like, who would I want to proactively start metformin with when I'm starting an atypical antipsychotic? What does that look like for someone on clozapine versus other antipsychotics? But more broadly than that, how am I thinking about prevention in terms of like their whole health? Certainly I think rather than it being like an afterthought, like, oh, let's follow up with this, like having it being a real clear part of care, that whether that be linking to like a WHAM like model where we're thinking about whole health right away. But I think it needs to be standard of care to address tobacco cessation. And I think oftentimes it's like a little bit more of an afterthought or when people get stable, or that's not how I think about it. I think in whatever place in the care system we have a responsibility. Like there should be a reason we're not, as opposed to a reason to. I think that paradigm really needs to flip. And I think probably we know the best way to save lives is addressing tobacco cessation. And that's why I spent the time talking about varenicline. It's a huge misconception and assumption. And, there are a lot of resources with like Massachusetts Quit Line. There's a lot of ways we do that. We also I think can embed cancer screening in community mental health clinics for younger adults that may be also related to cervical cancer screening. And just we know for our older adults or even just over 40, right, we're going to get into breast cancer screening, colorectal cancer screening is now 45. We're talking about like skin cancer awareness. I think that then we get into like just very high rates of eligibility for lung cancer screening and how you can have a shared decision making kind of conversation. A lot of people are like, oh, you have to talk to your primary care doctor about that. Not true. You can talk to any clinician about that if you can document a shared decision-making conversation. So we embedded that in our clozapine clinic, and then people kind of walk over to get their lung screening in partnership with a radiologist who's interested in these like inequities. So I think there's a lot of potential to intervene across that continuum. I think probably like tobacco cessation and metabolic syndrome are where we spent most of our energy thus far. And it's because it's critically important. That's part of why this cancer space is a little bit less known. But I think one of the challenges is like whenever you do an intake for someone in, ACCS or in a new psychosis clinic or in the inpatient setting, like we're trying to develop like a standard of care of an assessment for like, what do we always ask about? Much like we would want to integrate asking about substance use disorders. We would want to integrate asking about health, and how do we kind of do that in a streamlined way and help people feel able to do that? I think the other thing that's really challenging, okay, like in the clozapine clinic, 200 patients. How many primary care practices do you think were represented amongst those 200? How many different physicians? 39 different PCP practices, 98 different clinicians. I mean, that's just the reality of how fragmented things are. Clearly, that's not an efficient way to work. And so there's multiple different ways to think about models. I think that my particular wheelhouse is this bridge to specialty care, just because you can't wait. And there's this urgency. And in that context, sometimes it's a little more resourced than primary care in terms of like rapidly making things happen. But there's this real need to think upfront and earlier, of course, to really mitigate these disparities. So I think those are all really important things to think about.
Yeah, absolutely. No, and I especially appreciate the thinking of this as a health equity, really, or something that's for health equity and, you know, people with serious mental illness as a population that has a lot of those barriers. So yeah, thank you.
Yeah.
I think so. We can take one more question if people have them. Happy to either unmute or put it in the chat. We'll give folks a minute. But also, if not, I really appreciate everybody joining us today, and Dr. Irwin for both sharing all of the wisdom that you have, and also your contact for, you know, follow up. I think it's great to, like you said, be building these networks.
Absolutely. Thank you so much for having me. I'm going to put my email in the chat, and you know, appreciate the time to talk with all of you.
Absolutely.
Yeah, Kelly, I got a private message saying just got called away, but wanted to say thank you. This is such an important but under-considered issue. I really appreciate the work going into this from one of the participants.
Thank you. No, that's very kind. And you guys are kind of, you know, often unsung in community mental health, keep it real. So like, it's good to build the bridges, right, to make the connection. So I'm happy to be here with you guys.
All right. Well, if that's everything, I think that's a great note to end on. Thanks everyone for joining. And yeah, we'll send follow-up information via email. Have a great Friday.
Thank you so much, everyone.